In trauma surgery, the surface of the abdomen is a highly unreliable narrator. A patient can present with pristine, unbroken skin while suffering lethal internal organ destruction underneath. A high-velocity bullet or piece of shrapnel leaves a clear physical path of destruction, but blunt trauma operates differently. Blast waves or direct, heavy compression distribute massive kinetic energy across a wide surface area. In sudden deceleration events, like severe automobile collisions, the harness abruptly halts the forward motion of the abdominal wall. The internal viscera, however, continue moving forward with immense momentum, crashing into the seatbelt's fulcrum. Because we cannot see through the skin, we have to reconstruct the physics of the impact. We map the external forces against the internal anatomy to deduce what failed. This deduction relies on two distinct physiological paths. The first separates the organs by type. Did a dense, solid organ rupture and bleed, or did a hollow viscous burst and leak? The second axis evaluates containment. We must determine if the escaping vascular fluid or luminal contents have breached the peritoneal cavity to spread freely, or if they remain tightly compartmentalized in the extraperitoneal tissue. By plotting the exact mechanism of injury against these anatomical and physiological boundaries, the internal damage becomes highly predictable before a single radiograph is taken. The liver, spleen, and kidneys are solid, dense, and relatively fixed in place. When broad compression drives these organs against unyielding bone, like the lower ribs or the vertebral column, the tissue splits. A split solid organ instantly begins to hemorrhage. The primary threat to the patient's life here is simple volume loss, leading directly to severe hypovolemia. The physiological response to this internal bleeding is uniform and aggressive. The heart rate spikes to compensate for the dropping volume. Respirations deepen into a sighing air hunger, and the patient becomes intensely, uncontrollably restless. As blood accumulates in the abdomen, percussion over the flanks produces a dull sound that shifts when the patient rolls over. If the patient is conscious, they can often isolate the specific site of the internal laceration with a single finger, a clinical finding known as the pointing sign. But a ruptured spleen doesn't always induce immediate shock. There is a distinct clinical trap known as delayed rupture, which is characterized by a deceptive, symptom-free lucid interval. Look at this cross-section of the spleen. The blunt trauma tears the highly vascular inner tissue, but the tough outer capsule holds. Blood pools directly underneath it, forming a subcapsular hematoma. This creates an isolated pressure pocket that stops the active bleeding, hiding the lethal injury for days, sometimes over 2 weeks. Inside the cavity, the greater omentum also intervenes. Acting as the policeman of the abdomen, this fatty, mobile tissue physically migrates to areas of inflammation, wrapping itself tightly around the damaged spleen to reinforce the clot. These biological patches are highly fragile. A sudden movement or a mild secondary infection lysing the coagulum is all it takes to break the seal. The capsule bursts, the omentum gives way, and unrestricted secondary hemorrhage floods the abdomen. Normal vital signs in the aftermath of blunt force do not equate to safety. In solid organ trauma, stability is a temporary state that requires continuous, serial reevaluation. Hollow organs, the stomach and intestines, fail under entirely different mechanical conditions. If a massive force compresses the abdomen while the patient's abdominal wall is tense and their glottis is closed, the trapped internal air pressure simply bursts the intestinal wall. The mechanism shifts during rapid deceleration. A fastened seatbelt creates a sharp fulcrum across the trunk. As the external body halts, the small intestine continues moving forward, violently detaching the gut from its mesentery base. A ruptured bowel releases highly infective luminal contents directly into the pristine peritoneal cavity. The intense chemical and bacterial irritation triggers the adjacent abdominal muscles to lock into an involuntary spasm, creating rigid guarding. Unlike the restless patient bleeding from a solid organ tear, a patient with peritonitis stays perfectly still. The inflamed parietal peritoneum is exquisitely sensitive. Any movement of the abdominal musculature induces severe, wincing pain. The shock of the trauma also halts normal intestinal peristalsis. Auscultation of the abdomen reveals total silence. Without motility to clear intestinal gas, the abdomen gradually distends as paralytic ileus sets in. On the skin surface, an exact imprint of the clothing or seatbelt can sometimes be seen. This pattern bruising, known as London sign, maps the exact compressive force that crushed the bowel against the vertebral column. This X-ray illustrates the definitive marker for a hollow viscous rupture. Free air escapes the perforated bowel, naturally rises through the fluid-filled peritoneal cavity, and collects as a distinct gas shadow trapped directly beneath the diaphragm. Internal hemorrhage kills directly by draining the circulatory system. Hollow viscous injuries kill by initiating the overwhelming systemic inflammatory cascade of peritonitis. The urinary bladder acts as the definitive test of these diagnostic axes. Its exact anatomical location dictates entirely different physical findings depending on where the rupture occurs. Extraperitoneal ruptures account for 90% of bladder injuries and are almost always tethered to severe pelvic fractures. Fascial bands holding the bladder are torn by the broken bone, forcing urine to extravasate outward into the deep prevesical tissues. The patient experiences an intense urge to void, but cannot pass urine. Their pulse elevates from the expanding pelvic hematoma, yet percussion directly above the pubis reveals no dullness. The bladder itself is entirely empty. Contrast this with an intraperitoneal rupture. This occurs when a full bladder takes a direct blow while the abdominal muscles are relaxed. The dome tears open, dumping urine directly into the free peritoneal cavity, triggering the rigid guarding and agonizing pain of widespread peritonitis. We must cleanly distinguish these ruptures from a torn urethra. Look at this pelvic cross-section. If the membranous urethra shears, urine leaks deep below, which displaces the prostate upward and backward. On a physical rectal exam, the prostate is entirely impalpable, a specific diagnostic marker known as Vermeulen sign. But with an intraperitoneal bladder rupture, the prostate remains firmly in its anatomical seat. Instead, the examining finger detects a distinct fluid-filled bulge, formed as escaped urine drops and pools heavily into the rectovesical pouch. The peritoneal lining is a rigid functional boundary. A leak outside of it creates a localized tissue complication. A leak inside of it instantly becomes a generalized surgical emergency. Accurate diagnosis in the acute abdomen requires you to triangulate the data, trace the exact physical mechanics of the blow, identify the physiological nature of the escaping fluid, and map the anatomical boundaries containing it. Discovering referred left shoulder pain, Kerr sign, or the fixed dullness of a clotted spleen, Balance's sign, does not happen by luck. They are the expected, highly specific physical outputs of internal mechanical failure. The most definitive diagnostic tool is not a single initial scan. It is the repeated, methodical palpation of the abdomen over hours. The internal pathology is actively evolving, and the physical examination must pace it. When you bypass the pristine surface skin and anchor your clinical reasoning strictly in biomechanics and anatomy, the internal damage will inevitably declare itself.